Bismillahirrahmanirrahim. This is the second part of the of the single ventricle pathology lecture. We will discuss some examples of single ventricle pathologies. Single ventricle pathologies, as we have said before, that the single ventricle pathology is a congenital heart disease that is unrepairable, in which two ventricle repair is not possible, either temporarily or permanently. So this is one example: hypoplastic left heart syndrome, in which the left side of the heart with the arch of the aorta are small. The most common single ventricle congenital cardiac lesion, usually fatal within a month when the PDA closes, because when it closes, no blood passes to the left side. These patients are PDA dependent. In this image, the left ventricle is small. Blood passes mainly from the left atrium to the right atrium through an ASD, and then to the right ventricle that is enlarged, and then to the pulmonary artery that gives the main blood supply to the body through the PDA. Characterized by single ventricle RV, variable hypoplasia of the left side, aortic stenosis or atresia, mitral stenosis or atresia, hypoplastic left ventricle, an ASD, a PDA, in which the patient is dependent on them. The patient is ASD and PDA dependent. If there is a restrictive ASD or no ASD, the pulmonary circulation becomes severely restrictive after birth, and QPQS becomes very low, necessitating urgent atrial septostomy. So both the systemic venous blood and the pulmonary venous blood, they mix to the right ventricle, and then in this case oxygen becomes affected by the cardiac output, the pulmonary vascular resistance, and the systemic vascular resistance. So we should, when we manage these patients, we should balance these conditions: systemic and pulmonary vascular resistance. An excess pulmonary blood flow would cause high oxygen saturation, decreased lung compliance, lung congestion, hepatomegaly, ventricular dilatation, AV valve regurg. If the lung is oligemic, the saturation is low, cyanosis and myocardial ischemia. If the cardiac output to the aorta is low, so low mixed venous oxygen saturation, high oxygen extraction ratio, oxygen saturation will be low, poor perfusion, lactic acidosis, hepatomegaly, and ventricular dilatation. Surgically, Norwood stage 1 palliation can be done, which is an arch repair. The pulmonary valve, which is large, becomes the new aorta. We will benefit from the large size of the pulmonary artery, so the pulmonary becomes the new aortic valve. The main pulmonary artery transection may be used we may use the main pulmonary artery to repair the arch and the ascending aorta, atrial septectomy, and an empty shunt. This is the Norwood. So we benefit from the size of the main pulmonary artery to become the aortic valve. So the pulmonary valve becomes the new aorta, and we use it to augment the arch. And then the blood flow to the pulmonary artery is through an MBT shunt. And in this case, the entire heart becomes oxygenated and the entire heart is, the blood in the entire heart is pumped through this new aorta to the aortic arch, and then some passes to the pulmonaries. Deep hypothermic circulatory arrest, plus or minus antegrade cerebral perfusion. Another surgery that can be done is the Giessen hybrid procedure. We do a bilateral pulmonary artery band, a PDA stent, so we keep the original condition, but we restrict the blood passing to the lungs and allow blood to pass through the PDA, and we put PDA stent to prevent its closure after birth, an ASD stent, and then after 3 to 6 months we remove these stents and we do an arch repair and a Glenn and then Fontaine. So in this case we eventually reach the Fontaine procedure. This is also a Norwood but with a Sano shunt. The Sano shunt is better because it avoids the coronary steal that occurs with an MBD shunt. This is the Giessen hybrid procedure. We allow blood to pass from the pulmonary artery through the PDA with a stent to the aorta, and we put bilateral bands on the pulmonary arteries to protect the lung. Then we repair the arch and we do a Glenn and later a Fontaine. Preoperative diagnosis is often in utero. Balance, we should keep the balance between the QP and QS. Signs of pulmonary congestion, of course. Signs of systemic and coronary hypoperfusion. Shock, lactic acidosis, renal failure, cardiac ischemia, and necrotizing enterocolitis. Spontaneous breathing on room air is preferred. Need for prostaglandin E1 to keep the PDA open. Room air to prevent closure of the PDA by oxygen. Diuretics, nasal CPAP may be useful to decrease lung congestion, and check for other cardiac and extracardiac anomalies. Intraoperative, we maintain the balance. Low FiO2, permissive hypoventilation, permissive hypercapnia, that is. We put high PEEP. Avoid central venous line in internal jugular vein or the subclavian vein to prevent their closure as a preparation for Glenn procedure, either now or in the future. Deep hypothermic circulatory arrest plus or minus antegrade cerebral perfusion, so we put ice around the head, we give methylprednisolone, pantoprazole to avoid the peptic ulcer due to the high steroid dose, thiopental for an isoelectrical brain activity to decrease the brain metabolism, and cerebral oximetry. We also in this case we should put the a right radial or right axillary line to monitor the brain perfusion during the antegrade cerebral perfusion. Management of weaning from cardiopulmonary bypass varies according to balance between pulmonary systemic vascular resistance and systemic diastolic pressure. Inotropic support with Merinone. We do a MUF, modified ultrafiltration after weaning. This increases hematocrit, removes excess water, inflammatory mediators, improves hemodynamics and pulmonary and renal function. When we remove, there's strong evidence that MUF decreases the SIRS, or the systemic inflammatory response syndrome caused by the bypass and the surgery. So it is good to be done. During MUF, the blood pressure may decrease a little, so we may increase the dose of the noradrenaline. Many suture lines and difficult hemostasis due to the long bypass time, so we need enough blood products. Use procoagulants with caution, especially with prosthetic shunts and stents and things like that. If we give for example the factor 7, activated factor 7, clot may form inside the shunts. Often the patient is transferred to the ICU with an open chest due to bleeding or unstable hemodynamics. If after surgery we find that there is a low oxygen saturation, so there are some possibilities like obstruction or thrombus in the MBT shunt, or maybe if the patient presents later, maybe the patient overgrew the shunt, so he needs a larger shunt, or pulmonary venous desaturation from the lung issues like lung dysfunction, or pulmonary veins obstruction, or restriction or a restriction in the ASD. Maybe the patient overgrew the ASD that was left for him in his when he was a neonate. A low cardiac output due to myocardial dysfunction, so maybe the cardiac output is low, or anemia. If the oxygen saturation is high, so maybe there is an obstruction in the arch, so more blood flows to the lungs, elevated systemic vascular resistance, or there are collaterals. Now we'll talk about tricuspid atresia. Of course, the venous return from the vena cava must pass through an ASD, so these patients are ASD dependent. Then blood flows to the left ventricle, and then there must be a VSD, and then blood flows to the lungs associated with hypoplastic RV. Mainly the infundibular portion is present, but with an absent inlet, an incompletely formed trabecular portion. May be associated with a small VSD, pulmonary stenosis, pulmonary atresia, TGA, or other anomalies. Preoperative, pulmonary stenosis may cause balanced circulation and the patient may grow well. If there is a pulmonary atresia, so these patients will be PDE dependent. So if there is an atresia, so there must be a PDA here, and the blood flows to the lungs through the PDA. So these patients would be PDA dependent, so they will need prostaglandin E1, noradrenaline, room air, and urgent intervention. Some are highly cyanotic, severe pulmonary stenosis, small VSD, or pulmonary atresia. Some have pulmonary overflow, congestive heart failure, and later develop pulmonary hypertension, like in this case. If there is a large VSD like this, and unprotected pulmonary circulation, so these patients would have high QPQS. So if there is no PS, so blood flows preferentially to the lungs, so the saturation will be high and the lung will be congested, and these patients would develop pulmonary hypertension quickly. If there is pulmonary stenosis, so the saturation would be balanced. If the stenosis is severe, the patient will be cyanotic with a low saturation, and if the pulmonary stenosis is moderate or mild, so the the QPQS would be balanced and the patient would grow well. Surgical and transcatheter at birth, if the baby has a pulmonary overflow, so he will need a pulmonary artery band. If the saturation is balanced, SpO2 around 85, so we would not need any intervention, and we will follow up the patient. If the patient is cyanotic, so either a PDE stent or an MBT shunt or a corrective surgery. TGA may need palliative, if the patient is a TGA, may need palliative switch. If there is a subaortic stenosis, so a subaortic stenosis resection or Demus case stencil, the DKS procedure may be done. This is the DKS. So if there is a stenosis, subaortic stenosis, so blood would flow to the pulmonaries preferentially and with a low cardiac output to the systemic circulation. So in this case, we will use the pulmonary valve as the new aorta. We will transect the pulmonary artery from the rest of the pulmonary circulation, and we will allow blood, and we will connect the stump of the pulmonary artery, the main pulmonary artery, to the aorta. So blood passes from the single ventricle to the arch. And then we would do a Glenn procedure to perfuse the lungs. Double inlet LV. Usually it is a double inlet LV. We said this before in the DORV when we talked about the DORV, double outlet right ventricle. We in the lectures for the left to right shunt, we said that we would find the DORV and the DILV common, but we would rarely find double inlet RV and double outlet LV, because in the embryology, during the fetal development of the heart, the left ventricle, the blood passes from the left ventricle, or from the part of the heart tube that will later become a left ventricle. This is the outlet of the tube. So the left ventricle, the right ventricle produces the truncus arteriosus, and the left ventricle, the part of the heart tube that receives the AV valves, later develops to become the left ventricle. So if this condition remains, both the AV valves, the mitral and tricuspid, would drain into the left ventricle, usually associated with the VSD, restrictive or not. At birth, the same. If the patient is with a pulmonary overflow, we need a band. If balanced, nothing will be done. If cyanotic, we need the invitation to a stent. If TGA, we need switch. If subaortic stenosis, we need a DKS. Mitral atresia is similar to tricuspid atresia, but may be part of hypoplastic left heart syndrome and treated like tricuspid atresia, but may need a Norwood procedure. Here ends the single ventricle lecture, but I will add a part about heterotaxy syndrome. The heterotaxy syndrome is right or left isomerism. We will talk about them. Isomerism is a condition in which the patient has two right sides or two left sides. So the patient has the right side of his body is mirror imaged on the left side. So the patient would have a right side with the right side structures of the body with a mirror image on the right side, and the left isomerism is two left sides. So in the right isomerism, you will notice that the right lung has three lobes as usual, but the left lung has three lobes also. So there are two right lungs, but another right lung on the left. The patient would not have a spleen, would have a liver on either side. So these patients are asplenic. So it is called asplenia because the spleen develops on the left side and the patient has no left side, has two right sides, so he would have an asplenia. More than 50% are single ventricle. That's why we chose to put these conditions here in the single ventricle pathology lectures. DORV and unbalanced common AV canal are common. Pulmonary stenosis, atresia are common. Bilateral SVC. So we'll notice that there are 2 right atriums and 2 SVCs. So the patient would have a right SVC and a left SVC, and both drain to the right atrium with the right atrial anatomy, like right atrial appendage, 2 right atrial appendages. Extracardiac total anomalous pulmonary venous drainage is common because we do not have a venous drainage from the lungs, because lungs drain to the left atrium. So if there is no left atrium, so maybe the venous return of the lungs would not develop. So a collateral appears to drain the lungs to the heart, and this collateral, if above the heart, would be a supracardiac; if to the heart, the coronary sinus, would be a cardiac or infracardiac. Bilateral SA nodes. Since we have 2 right atria, so we would have 2 SA nodes, and they would compete with each other. So we would have a sinus rhythm, but with the P wave shifting from upwards to downwards according to which SA node is more dominant. Bilateral trilobed lungs, midline liver, intestinal malrotation, requiring lifelong penicillin, pneumococcal and meningococcal vaccines and strict infection control, because these patients who are lacking the spleen would be immunocompromised. In left isomerism, the single ventricle is less than 50%. We would have an interrupted IVC, so an absent IVC. So because we would have 2 left atria with 2 left atrial appendages. The lungs would be bilobed bilaterally. Would have a cardiac type total anomalous pulmonary venous drainage, an absent SA node, so we would have a sick sinus syndrome or bradyarrhythmias, because we do not have an SA node. So any focus may predominate the heart rhythm, and we would have a polysplenia, multiple spleens, and that would not be a problem. This is a normal situs. The right atrial appendage and the left atrial appendage is with a narrow opening, and that is long and narrow, but the right atrial appendage has a wide base. In left isomerism, we would have 2 left atrial appendages, and in the right isomerism, we would have 2 right atrial appendages. Thank you.